board certified in physical medicine, rehabilitation, and also in brain injury medicine.
Primarily, I teach in the athletic training education program, and I've been doing that here at the University of Montana for about 13 years. And the other part of my job is I work as part of our community outreach program, primarily working with youth hockey players.
My name's Braxton Norwood. I have a small biotech company based in Kalispell, Montana, and we are focused on the development of therapeutics for neurological disorders. One example is traumatic brain injury.
My name's Kathy Off. I'm a speech-language pathologist and associate professor at the University of Montana. My areas of specialty are in acquired neurologic disorders.
Hey, my name's Saj Patel. I'm a research associate faculty member here at the University of Montana, and I run a research lab looking at blood-based biomarkers for traumatic brain injury and other neurological disorders.
My name is Peyton Agnew. I graduated college in 2017 after playing 4 years of soccer for the Grizz. And now I am working at youth homes at the Talbot Boys Home, and I coach soccer for a bunch of different age groups. Well, I had 3 concussions while I was in college, one my freshman year, one my sophomore year, and then I got one the summer before my senior year. The one that I did a lot of work with the university was after my sophomore year concussion. I took an elbow to the face in a game and got a black eye and a concussion and was out for 4 weeks, I think. But then I ended up being cleared to play for the last season, or the last game of the season, but then didn't actually come on the field, and then I had a couple more months to recover.
So I was wounded in 2006. A car bomb got me in Kirkuk, Iraq, leading a dismounted patrol.
We just don't have a full understanding of the long-term risk for health, and then just having a good understanding of really how to make sure that they're properly taken care of if they do sustain a head injury. There's a culture to break through.
Even though I'm not playing anymore, I coach a lot of girls, and I see them get concussions, and I wish there was more that I could do or say, and I like to think that I kind of know what I'm talking about, just having gone through the process so much. But like I said before, there's so many things that we don't know that I don't even know if I'm keeping them safe as much as I want to be.
When we look at it more of a regional or local level, Montana, for example, has one of the highest, if not the highest, incidence and prevalence of brain injury of any state. We have 1 million people. We have a very challenging physical geography, a very challenging socioeconomic concern here in the state, and everything is really spread out. So, for example, if you have a problem or you have a head injury or you need treatment, I mean, you could be a long way from a facility that would be able to treat said injury. So any type of research at a local level, international level, can be filtered down and pushed down to areas of emphasis that can actually reach out and help those in need.
In a state like Montana, with the kind of workforce that we have, outdoors, agriculture, construction, there's a high propensity of these injuries in that population.
Our research is focused on concussion-induced brain injury, epilepsy, Alzheimer's disease. These are all things that are a little bit different, but the common thread is brain injury, neurodegeneration, the death of neurons, physical injury to the brain. And there's a lot of overlap in those things. Memory issues are common, which has to do with injury to certain areas of the brain. So while they are a little bit different, there's a lot of overlap. And some of the projects we're working on seem to be applicable to multiple areas in that they do prevent brain injury in different modalities.
One of the largest areas of research, especially related to traumatic brain injury, is finding accurate objective measures to assess the injuries and the outcomes. And so there are many, many groups all over the world working towards that goal. And Our primary focus is on a group of small molecules called microRNAs, which we believe are changed in the brain following these injuries. And we also believe that they can get into the systemic blood circulation out of the brain, which makes them very attractive molecules to study as potential biomarkers.
Well, I've been doing research on the physical examination and using virtual reality to assess patients who've suffered trauma. And then also I'm involved in just the physical exam itself in brain injury, as well as other traumatic events.
I have a particular interest in understanding the components of rehabilitation that can kind of harness neuroplasticity. So we know that the brain is capable of remarkable change even in the event of injury, but we're not really good yet as practitioners and as scientists in really understanding how it is that we can really help people move forward from an injury, from either something like a traumatic brain injury, from an accident, or from a stroke. So I'm interested in understanding there are some things called principles of neuroplasticity, which of these principles can most optimally or most maximally push the rehab process in a way that helps us to really reduce the cost to the patient and the number of years that they're participating in rehabilitation. So one of the components of plasticity that I'm interested in understanding more about is how intensive programs need to be. So kind of the standard of care once a person is past the acute phase of rehabilitation is to go in to see their therapist once or twice a week. And we're learning quite quickly now that that's not enough to really affect the change at the brain level that we want to see.
So one of the cornerstones of the work that we're doing here in my lab is to try and understand the kinds of molecular changes that are occurring in the brain following these injuries. These injuries are very heterogeneous. They're as individual as the individuals that get them. Obviously, the brain is a very complex organ, and a lot of research is focused on trying to really understand at a molecular level what changes are occurring in the brain, so we can find commonalities within all these different injuries and in all these different individuals, and try and get a handle on markers, as we call them, biomarkers, that we could use to try and predict, one, the presence of an injury, potentially how severe, and then also project to see, based on how these biomarkers may change, what the possible outcomes for individuals who suffer these injuries are likely to be.
The research that I've done with VR testing has validated what I've seen in the office. So there are many things that I've seen, and I believe that they're objective findings, but again, it's qualitative in that I have no way to measure them. And with VR testing, I've been able to take those same patients and digitalize their response and then look at the data that the computer analyzes. And so we use a VR system. Actually, I have the headset here. So we have the patient wearing this, and we do various auditory and visual tests with it. And we can measure their responses and how many errors they make, how long it takes them to make decisions. So in Canada, they're doing the same type of research with robotics, and it's a much more expensive way to measure the same thing. It's also much less available because you have to buy $100,000 worth of material to evaluate the patient, whereas with VR, it's about $1,800 to buy the equipment and then assess people. And it is a more accurate, standardized way of assessing people than the physical exam. The physical exam that we do in brain injury medicine is, for the most part, the same as it's been done over 100 years. And so it really hasn't changed. And so the VR brings it up to another level, and that's been recognized in stroke as well, that utilizing computer technology, we can better evaluate patients. And so I see that as a new frontier in medicine in general, but in particular in brain injury, but it'd be applicable to many other diseases that cause neurologic dysfunction. Patients getting chemotherapy, patients developing side effects from medicines, screening tests for Alzheimer's, which would be much more precise and detect these problems much earlier. Same with Parkinson's. So the research that's being done in brain injury would be applicable to other fields of medicine as well.
It was really informative. I don't really, from what everyone says, we don't know a lot about concussions and how to tell who has one and how long they need to sit for and what is healthy and what is not. And I learned a lot about how far behind we are in research by participating in this research. It's also really cool to be a part of something like that, even though the experience itself really kind of sucked and I did not want to have a concussion. Sarge and Tom were really great, and I do think it helped me understand what was going on, and it was just kind of another tool to make sure that I was being healthy and safe, and another hoop to jump through before I got cleared to just know where I'm at, which helped a lot.
When I see patients, I tell them it's as if you had a blank canvas and you took a 6-inch house paintbrush and you splattered the paint on the wall, and that's how the injury occurs. So there are certain areas that are more likely to get injured, but even if there are some similarities in where the injury is, how the individual responds to that injury can be very different from one patient to another. And so it's very experimental in treating all patients. And there are certain parts of the nervous system that are completely overlooked. Most brain injury doctors look at either the brain as being injured or the cervical spine or a combination of the two, but there's a major integrating part between those two called the brainstem that really has been almost completely neglected.
One of the things that I think is unique in particular about my research and quite a few of my colleagues here in the Speech, Language, and Hearing Sciences department is that we are all translational researchers. So we're trying to figure out how to take principles that we're learning in our labs and implement them as quickly as possible into clinical settings. This lends a really lovely ability for us to blend teaching and research with our graduate student clinicians and our undergraduate students. So I think for us, there is a really lovely blend of research and teaching. But I think from a bigger picture, when you kind of step out, the emphasis is always on teaching. If it's separated in the very beginning, like here's my teachers who do research and here's my teachers who teach, and if they're not blended from the very beginning, then you end up with this idea that research is somehow separate from your day-to-day job, and the research is integral to clinical practice.
As a consumer advocate, or that's kind of a strong word to use, but sort of a consumer scientist, there's probably a better term for it, I'm afforded the opportunity to work with leaders in the field, not only in research, but those that dictate or make and dictate policy. And by being able to bring a face and a voice and a humanistic component to this research, it really opens a lot of doors for people and lets them see the intricacies that are associated with this injury on a primary, secondary, and tertiary level, to include not only the injury mechanisms themselves for the individual, but caregivers, family members, their community, and things that an individual that suffered this type of injury will need to move forward in life.
So I think that's the important piece, right? Because so we have to have the information to be able to make decisions and informed decisions about policy.
It changed my career path. The Army at that point more or less told me I couldn't command anymore, and being that I would not leave the infantry, it was time for me to move on. It created a lot of problems, social, emotional, until I was able to learn compensatory strategies. In my case, I plateaued after 3 years, but there's other things that you have to take into consideration. It also, on a positive component, opened up a door for me to participate in policy analysis to participate in my role working with medical researchers, to be able to be a voice for those that maybe don't have a voice, to be able to help people, put them where they needed to go. But as with anything with the injury, you have to reinvent because you can't go back to what you did. So, and that's the trick, find out what you can do and sort of how you can help and then how you can fit in. And once you're able to put your fingers, grasp that concept, you're able to move forward, shift gears. And then in my case, I came back to school. It was a nice way to stay current, to stay focused, to stay intellectually engaged.
I wanted to make sure, not only for my kids, but for kids' friends and other families that I see dealing with head injuries, that they have the appropriate resources available to them.
Speaking very frankly and honestly, when I first started this project, I actually didn't know very much about how traumatic brain injury and concussion actually impacted the populace, individuals. I came at it from a very scientific method point of view, but as our research grew and we started making the findings that we did, and then we started engaging with patients and individuals who suffer these injuries, hearing those stories, the whole gamut, folks in the military, athletes, obviously was a big part of what we did here at the university.
For me, I typically had a lot of nausea and a lot of sensitivity to light, a lot of issues tracking the ball, watching people move, anything like that. So I was cleared to play after 4 weeks. The return to play process that time took me 4 weeks, and then afterwards, when I was technically cleared, but then once season ended, we were off. So I just took our winter season pretty easily.
You really get to see the impact of some of these injuries and just how folks are suffering from these. And sometimes it's as simple as acknowledging that these individuals are suffering, because sometimes you have these head injuries and there's no physical indication that somebody has suffered this injury. And I think for that population, sometimes getting the acknowledgement that I'm not just making this up, this is a real injury and I have real issues that I'm dealing with. I think that was the most impactful thing that I was able to see, and it changed my point of view.
The one that I ran across frequently was people thought I was drunk because the speech, sometimes when you speak, the words that you formulate don't necessarily come out that way. And I mean, this is college, let's face it, we've all had a few beers a day, but it became very frustrating sometimes, and then being able to explain to people that this wasn't the case. And then how many times do you ask someone, have you been drinking? Of course they're going to say no, but once people got their fingers, once again, wrapped around that concept, then it wasn't that difficult. Fatigue was a big one. I'm constantly tired, but I'm able to overcome some of that. And unfortunately, and I don't know, and I'll be very honest with you, if this was directly related to the head injury, but I developed multiple sclerosis several years ago, which that's a whole different set of issues within itself. Other challenges associated with it, in my case, and this is the thing about brain injury, I guess I should back up here a minute, no two people are the same. This is not a one-size-fits-all injury. When somebody breaks a leg, you put a cast on it, keep your fingers crossed, nothing bad happens, then you're back to walking, down the road. With this injury and the sequelae, it can manifest itself in many, many different ways. For some people, it's like in my case, it's fatigue. For some people, they have issues with anxiety, with anger. I have difficulty driving at night. Some people don't. Some people are not able to follow complex conversations with 3 or 4 more people. For example, we're having this interview here. It's fine, there's no one around. But if there were 3 or 4 people and distractions, it could be, maybe not for me, but it could be difficult. Other issues associated with it is sort of the treatment. It's very difficult for individuals to be able, or maybe even have the drive to meet providers halfway, to engage in some of these treatments. It's not necessarily always a hidden injury. And back in the day, they used to refer to it as mild TBI, moderate TBI, and severe. In my case, it was moderate. But mild TBI has kind of gone away because if you have a head injury, how is it mild if it's manifesting symptoms? So it's, as I say, I guess loosely translated, it's not a one-size-fits-all policy. When you treat this injury, you got to check your ego at the door. You're going to be working with all types of different people depending on the research that's coming out and depending on the severity of the injury. And if you don't know, you need to ask. And that's why it's critical that you bring in case managers, social workers, nurses, and folks that sometimes are excluded for whatever reason from the established medical concept. Without these critical components, it's not going to happen.
Well, so initially I wasn't allowed, once you get a concussion, I wasn't allowed to go to class or to practice at all. I sat at home for the first couple days. When I started to try to go back to class right away, I experienced some problems. I would take notes and not finish my sentences, kind of trail off the page in my writing, make a lot of grammatical errors, and then when I would flip back that night when I went home, a lot of it didn't really make a ton of sense. But then after, I'd say probably 4 or 5 days, I was able to sit mostly through classes. I had some issues like getting to class, like the walk to class would give me a headache, and then I'd have to kind of sit out of class just because like going up the stairs.
Oftentimes they're referred to as the miserable minority because they look okay, but they really don't understand how tumultuous the nervous system is working. The nervous system is essentially a bunch of electrical circuits and that are interconnected by chemical transmitters. And everything's in balance, and when you have an injury, you change that circuitry. And so things are no longer in balance. And so someone can look good on the outside, but on the inside they're suffering or struggling. It's kind of like going into a house and none of the light switches work to the appropriate room anymore. And so you've got to run around the house and turn on different switches to get things to work. And that's really what's going on inside the brain at a much more, finite level.
There are so many cognitive and psychosocial and emotional consequences of head injury that these families are coping with for a really long period of time. And so for me, the power that these families have had on my life is pretty extraordinary.
Our single blood-based biomarker isn't going to be the answer for helping individuals with these injuries. There's so much more. It's so much more complex. But understanding, at a base level, understanding exactly what's happening to a particular individual, and each individual's needs are different, and so the outcomes are very different.
Well, I think there's a lot of different avenues that we need to explore to fully understand just brain injuries in general. And so one, I think, again, the diagnostic piece in helping different healthcare providers be able to readily and accessibly be able to diagnose a head injury on different patients. Again, for me specifically, from the athletic training side of things, looking more of like a sideline assessment and having a definitive assessment to be able to make that decision would be nice. And then, I think there's a lot of work that still needs to be done around policy and education. And that's where a lot of my focus has been in terms of research, looking at how to improve policies to protect particularly our youth athletes. And then a lot of education, because there's a lot of misinformation that still circulates about just head injuries in general.
The pie in the sky is that everybody is looking for the quick fix, the pill, if you will, that will fix the injury. And there's been a lot of progress made in that area, looking at off-market drugs such as like Alzheimer's and Parkinson's, bringing them in, different medications, different regimes, but everybody is looking for the quick fix. But the practical answer is that it's still going to take us a while to get there. There's been some unbelievable advancements, especially in the realms of transcranial magnetic stimulation, certain forms, and I'm not the biggest fan of psychotherapy by any stretch of the imagination, but it's actually been used to some sort of positive efficacy with respect to TBI and revisiting sort of the nature of the injury. There's been a lot of advancements in some of the things I just discussed by people actually starting to understand and bring in the coordination of care and the interdisciplinary concept. Made great advancements, great strides within the injury, especially dealing with some of the sequelae and some of the underlying, emotional, physical, and sort of mental concepts that go with it. But you know, as positive as I want to be when I say that, I'm also a realist, and we're not there yet. You know, could there be a breakthrough next year? Absolutely. Could it be 10 years? I don't know. But I think the trick is, and the message to take away is to stay positive, proactive, and be aggressive, you know, in meeting the challenges that are dictated.
So right now in the clinic, so what we're hoping, our end goal would be to have a patient be able to come in and we can take just a small drop of blood or any biological sample. We want to make it as easy and as less invasive as possible. And so, you know, we hope to have a kit or a test where we can basically take a drop of blood and get an answer very, very quickly, maybe in less than an hour, or maybe in the clinician's office. And then, you know, give the patient some insight about what has changed.
I think there are several areas. One is better diagnoses. Another is immediate treatment. I would hope that in 10 years or so we have some kind of pharmacological cocktail that patients could take, or some type of IV drug that once they're diagnosed as having a brain injury or having the potential of having suffered one, that they can take a drug that'll eliminate or decrease the effects of that injury. We're also seeing better prevention. Cars are safer. We're seeing, on a relative scale, fewer catastrophic injuries because cars are safer. And I think the long-term treatment will get better too as we develop new drugs and new strategies. You know, 15 years ago, we didn't use any adaptive equipment for cognitive dysfunction, and now people are using smartphones and things of that nature, and being much more successful and independent utilizing that type of equipment. So I think that with virtual reality and artificial intelligence, we have opportunities to help people be more functional.
So rather than, say, developing a new helmet that reduces the impact, something that actually can correct the injury, or even if you could take a drug before a football game and prevent that injury from happening, where you're not trying to reduce like the impact severity, but you're actually trying to block the brain injury. And I think that's where the field is headed, and there are more companies and more scientists that are looking at therapeutic interventions, but there are also people looking to reduce the severity of injury, which is also very important.
Well, I mean, ultimately, and this is an easy sort of statement to make, but hopefully a cure of some kind, right? That we can use to help at least limit the long-term consequences of these injuries. It's such a complex disorder, so multifaceted. There's not going to be any one single thing, I think. Much like as researchers, we're trying to get a handle on the disorder and the disease and the long-term outcomes. You know, it takes a very multimodal, lots of different backgrounds to answer these questions and impact this disorder. Diagnosis, accurate diagnosis is going to be key because that's at the very front end. And then tools that allow us to better prognose what are the potential outcomes for individuals suffering from these disorders. And then obviously intervention would be the biggest thing. And it's such a global, huge statement to make. I mean, ultimately, we want to help every single one of these people.
I would love to know what my brain is like when it's healthy versus when it's not. I think a lot of things kind of get overlooked as normal, and you don't really know if you're okay when you're not, or if you're not okay. If you're not getting headaches anymore, you assume that you're healthy and you're ready to go, but that might not necessarily be the case. And I would really like some sort of test or some way to prove that, yeah, your brain is ready to continue whatever it was that you were doing, or no, you need to hang back a little bit. I think it would also be really neat to know how it'll affect your brain in the future. I mean, I don't know if in 30 years I will have some memory issues or whatever it might be related to this or not. And that would have been really useful to know as a player, just to kind of inform your decision on, you know, for me, I played soccer and I didn't ever quit, but if I knew that in 30 years I was going to have some cognitive lapses, it probably would have impacted my decision to keep playing. So that sort of information, just to kind of make a knowledgeable decision, would be really useful, in my opinion.
I think that right now we're kind of on the cusp of really understanding a lot more about the neurobiological consequences of brain injury. So there are a lot of individuals who are looking at how do we figure out, how do we identify brain injury really early? And so if we identify it quicker, are we able to then provide intervention sooner? So I think there's a lot of excitement right now about learning about biomarkers for concussion and how to identify these injuries very early on. But I also think that we are at a place where we're starting to really understand the impact that an interprofessional, interdisciplinary team can have on the rehabilitation process, and how these interprofessional teams can kind of change the delivery method so that rehabilitation is more seamless. So I think between better understanding of kind of the true neurobiology of the injury and how to predict recovery, and then also this idea of how do we better rehabilitate and educate families, and also systems, so school systems and work systems, so that people can re-engage in their education or vocational lives after injury.
My hope for the future is that, we can, as scientists, we can all come together and bring all these unique knowledge bases together to really answer the big questions.